Greetings, everyone. My name is Jean-Pierre Kikens from the information portal covexit.com, and today we are very pleased to welcome as a guest for this interview Dr. Varon. Dr. Varon is a professor of acute and continuing care at the University of Texas Health Science Center, and he's the Chief of Staff and Chief of Critical Care at the United Memorial Medical Center in Houston, Texas. Professor Varon, welcome.
Thank you.
So we are extremely pleased to welcome Professor Varon, and the whole concept of this interview is to go through two areas. One is the stages of the disease COVID-19, and the second is going to go into some depth into some of the key issues associated with the disease. The first part of the interview will cover prophylaxis, mildly symptomatic patients, and 10 more advanced stages of the disease. And you can see right away what are the areas we are going to cover in the second part. We'll get into the details later. So let's jump immediately to the stages of the disease. Professor Varon, can you comment on those, please?
Yes, I mean, when you look at any disease, and this is not just particularly to COVID, especially when we're dealing with an infectious disease such as COVID, in which you have a part where the virus first infects your body, and then a second part where the virus has kind of triggered a series of reactions in your body that really get you sick. You can talk about a first incubation phase, which is the part where you got a contagion from somebody. The virus is slowly getting into your cells, especially into the lung cells. Then you start having a second phase, which is a phase where you start having symptoms. And the symptoms may vary. I mean, we have now been learning a lot of new symptoms coming from COVID. After you start having these early symptoms, you have what we know as the early pulmonary phase. The early pulmonary phase is when you start having a little bit of shortness of breath, it's a little bit of a cough, you start having evidence of pneumonia on your chest x-rays or CAT scans. And then you have what we know as the late pulmonary phase. And during the late pulmonary phase, that's when you are really sick, and that's when people may die.
And can you explain the transition from this viral infection towards inflammatory response?
Yes, I can. First of all, you need to understand that COVID, or coronavirus infection, is a very fluid illness. It's an illness that keeps on changing, and we keep on learning things. The way I approach my patients today is completely different than what I used to do 8 weeks ago. We have learned a lot of new information. Initially, we used to think that there was an incubation process of about 4 to 5 days, but we actually have seen patients that have taken much longer than that. Then you have an inflammatory response that in many patients starts at the very beginning. Once you start having that incubation, once the virus gets attached to you, you start having a process of inflammation. But the process of inflammation really is not going to start peaking until the second week or so. And between the 11th and 14th day, that's when you start getting a peak. And then when you start getting in trouble is when your body has generated so much inflammation that your lungs are so inflamed that you basically cannot breathe. Simultaneously, while you're having that, many other organs are being affected. You start clotting all over the place. You start having micro clots that eventually will affect organs like the heart, the kidneys, the brain, things like that.
And just to be precise, when you say that this inflammatory phase starts around the second week, it's the second week after the first symptoms?
That's the second week after you get the infection. However, having said that, we have and that's why I want to be very clear with the people that are watching this. That happens in a lot of people, but more and more we're learning that some of these symptoms, some of these severe inflammations can occur weeks later, not necessarily at the very beginning, like our graphs have shown.
Okay. And the key symptoms from your perspectives are which one?
I would tell you, over the last 65 days, I have seen every possible symptom known to mankind. I have seen people that present with headaches. I have seen people that present with lack of smell, lack of taste. I have had people that present with a classic fever, dry cough, chills. Those were used to be called the classic ones. But I have seen people that come to me because they have a rash or they have a belly pain. Actually, one of the first patients that we admitted to the hospital had severe belly pain, abdominal pain. We actually thought that he maybe had an appendix or some issue like that. And we just didn't think about COVID presenting like that. We're seeing a lot of diarrhea. Indeed, there are a few studies that have shown that if you were to look for the COVID virus in the stool of patients, you can see it 3 days before you start having the other symptoms, even if you don't have diarrhea. So that's the problem of this illness. And that's why it is extremely important that we do testing, and retesting. Because the fact that you're negative one time doesn't mean you're going to be negative the next time.
And so your advice is to come as early as possible once you have some symptoms that you suspect any.
I would say that, the moment you have something that is not your usual, if you're a person that gets headaches all the time, that you have chronic migraines, I wouldn't concern about that. But if you have any symptom that you have not had before, doesn't matter what it is, I think you need to seek medical advice.
Okay. The slide you just saw was actually produced by Professor Marik from the Eastern Virginia Medical School. Can you explain a bit the collaboration you are having with Professor Marik and others regarding the development of protocols for treating COVID-19?
Professor Marik is the person that I call a brother from another mother. Professor Marik and I, we have been working together in a variety of different academic things for probably 28 years or so. I've known of his work for many, many years, and he has some areas of particular interest that he has been doing. He's been doing a lot of work on sepsis, which is overwhelming infections that people get. I've been doing some work in other areas, and together we have done many, 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 many studies, papers, just name it. Professor Marik, a few years back, approached me and asked me whether or not I was interested in talking about a theory that he had, and that was that giving people ascorbic acid, vitamin C, giving cortisone would make a difference in the outcome of patients that had these overwhelming infections. And, we decided to start testing this hypothesis, and we actually found that our patients that had infections, when they had sepsis, and we gave them ascorbic acid, we gave them thiamine, which is another vitamin, as well as cortisone-like agents, they were doing very well. Their mortality rates went down. They left the hospital early. So when the pandemic approached, the very first thing that we talked about was, hey, what would happen if we give this cocktail, quote unquote, to patients that have COVID? And that's how we started this idea of giving patients what we now have called the MAD Plus protocol.
As a sequence, maybe even before someone gets the disease or any kind of symptoms, the protocol developed by Professor Marik makes suggestions regarding prophylaxis, vitamin C, quercetin, zinc, D, melatonin. Can you explain the rationale of the prophylaxis protocol?
Well, I guess, if you remember what your grandmother used to tell you when you wanted to fight a cold was have vitamin C. I'm sure that, we all had somebody give us a lot of vitamin C to prevent colds. Well, guess what? It works. And it works by a variety of different mechanisms. Some of them are directly related with the antioxidant properties that ascorbic acid has. However, these prophylaxis that we have actually recommended not only includes vitamin C, we also suggest the use of zinc. We suggest the use of melatonin, and it's not because we want you to sleep better, but because all of these medications actually decrease the inflammatory response that the virus is generating. We recommend that people use vitamin D. We actually have found that patients that get in trouble with COVID tend to have very low or non-existent vitamin D levels. When you compare people from, let's say, the south of the United States and the north of the United States, those people of the north of the United States, for example, the people in New York, they have a much higher mortality than the people in the south. Well, why? Because we have more sun here in the south of the United States. We have higher levels of vitamin D, so we recommend vitamin D. And more recently, there's a lot of hype about the use of famotidine. Famotidine is one of those medications that people were using for stomach ulcers and gastritis and stuff like that, that have also been found. All of them, they seem to do is they seem to contain that inflammatory response that you have at different levels, molecularly speaking.
Can you elaborate regarding zinc? Because zinc is very much talked about as kind of an essential complement, especially with hydroxychloroquine at later stages.
Yes, and I'll be glad to say that. I mean, all of these reactions that you have in your body require a variety of what we call cofactors. If you remember from your chemistry classes a long time ago, they used to tell you, in order to go from A to B, you need a little something that's going to give a boost to either an enzyme that catalyzes that reaction. Well, zinc is one of those. Zinc is a fascinating cofactor that we can use to accelerate some of the good reactions that the body needs.
Okay, let's move to the next phase, which is mildly symptomatic patients who are at home. Can you comment on that part of the protocol?
Yes, and again, this is something, and even though I tell people don't do this at home, you can do it at home if you're doing it under medical supervision. I mean, what we do is we do the same things that we discussed earlier, the vitamin C, the zinc, the melatonin, the vitamin D. But in addition, and as an option, we recommend that you take hydroxychloroquine. We ask people to get 400 milligrams twice a day for 1 day, and then 200 milligrams twice a day for 4 days. We have found that hydroxychloroquine works. We don't politicize that agent. We have seen in our experience, it works. I have given it to patients in the outpatient setting, but only if I know that, one, they don't have any pre-existing heart conditions. Two, this is done by a physician and there's appropriate follow-up. Another option, if you don't like to use hydroxychloroquine, is to use an anti-parasite that is actually given to dogs, which is called ivermectin. Ivermectin, we give either a single dose, that's one option, or the other option that we have recently started to use is 15 milligrams every day for 5 days. So you can do it either way, 1 dose or 5 doses. A little bit of aspirin has also been shown to help, and as we said earlier, famotidine, which is the anti-ulcer medication, also work. Now, it is important that you realize that all of these patients must have their oxygen levels checked, because when you have going from very mildly symptomatic to being near death, that can be an overnight thing. So if your oxygen levels are low, and by low, contrary to other medical illnesses, I mean, I tend to tolerate kind of low oxygens, but if I have an oxygen of less than 94, then I am concerned that these patients probably are not mildly symptomatic, and these patients may need to be seen in the hospital setting.
Okay, and just a clarification, if you compare to the protocol of Professor Didier Raoult in France, so there is no azithromycin in your protocol?
No, there is not at the present time. And there are several reasons for that. We know that azithromycin prolongs what we know as the QT interval. The QT interval is when you have your little EKG thingy, it kind of stretches it out. So if you put azithromycin and you put hydroxychloroquine, which also does that, the concern is that instead of having a line like this, you're going to be pulling them from both ends, and then you're going to have a straight line. And remember, these are people that are not being monitored.
Okay. So next phase is mildly asymptomatic patients, but on the floor.
And these are the patients that we already know that their oxygen levels are probably 94 or less. So we give them the vitamin C. We give them a reasonable dose of vitamin C. We do like 500 milligrams by mouth every 6 hours. We give them the zinc. We give them melatonin. We give them the vitamin D. But at this point in time, we introduce a blood thinner. A blood thinner that we give as a shot. We give it as a once a day. So it's kind of like, it's preventing new clots from forming, or clots from forming. We give you the famotidine. And the other thing that we introduce is the use of steroids, which is cortisone-like agents. We do that because, as I told you before, one of the things that corona does, it gives you a gigantic inflammatory response. This gigantic inflammatory response, what's going to do is going to basically swell up, if you want, your areas of the lung where gas exchange occurs, and you will suffocate to death. So what we do is we give this very potent steroid to start to decrease the inflammation. And then optionally, we give you the hydroxychloroquine in the same doses that I mentioned before.
Okay. The next slide is regarding more advanced stages of the disease, and I don't think this is the right place to go into details, but generally speaking, can you explain a bit how you are dealing with as long as the disease evolves, or if someone shows up and is already pretty advanced, you see?
Well, what you do at that point in time is the first thing is you admit them to a unit where you can monitor them continuously. Most of the time it's an intensive care unit. You give them a hell of a lot of cortisone-like agents, of the steroids that we spoke about. You give a lot of vitamin C. You give up to 3 grams by vein, not even by mouth, because we know that the absorption by mouth may be not as good as giving it by vein. And instead of giving you agents to prevent clotting, we're giving you agents that we're thinking that you already have clots, maybe microclots. So we give you the full anticoagulation. We give you the full blood thinner to do that. In addition to that, if we think that you are very sick, we add an antibiotic, which is called azithromycin, this famous Z-Pak, in addition to a couple of other agents. For example, we give a cholesterol agent, which is called atorvastatin. And the reason why we do that is because that's also a very potent anti-inflammatory. Most of the agents that we're using to treat patients with probably severe COVID, we do so with the hopes that they will work as an anti-inflammatory agent. Not that much for their antibacterial or antiviral capacities. We try to keep these patients relatively dry from a fluid standpoint. And depending on what's going on, we are very picky, if you want, as to what kind of things do we monitor. We monitor a series of blood tests to get an idea, are these patients going to get worse with what we call the storm, the famous COVID storm. And the storm is when you start having release of all these inflammatory mediators, all these inflammatory things that your body produces that are going to kill you. So we are very aggressive to take care of those.
Okay. And so regarding all this question of ventilation, we'll get into the details later on, but the general idea is to avoid ventilation.
I'm going to tell you, today in my ICU, I don't have a single patient ventilated. Not one. Not one, because we know from the data from Europe, as well as the data from New York, is that if you place a patient with COVID on a ventilator, they have less than 10% chances of leaving the hospital alive in one piece. So we do everything that we can to avoid intubation. And that's one of the most fascinating things, because if you see me do my usual rounds outside the COVID intensive care, on a regular intensive care, if you sneeze, I'll put a tube in your throat, I'll put you on a ventilator. If I'm in the COVID unit, I do everything I can to avoid putting a tube in your throat. Whatever I have to do, I'll do it to avoid it. Because I know that once I put that tube in, either the tube doesn't come out or you don't come out.
Okay, let's move to the second part and let's go through the several aspects here just to name them. So the first question, how to avoid mortality, lung damage and other sequels. The other one is maybe to elaborate on just what you mentioned about intubation, how to protect oneself, how to protect the medical personnel from infection. We may go back to early treatment, how to proceed with early treatment, the question of telemedicine. Young people, usually it's considered a elderly people issue, but young people also are susceptible to develop this disease, of course. What about the elderly? And the need for potential more information and research. So that's what we are going to go through. And maybe first, if you can comment about how to avoid mortality, what can we do to avoid mortality? We are all susceptible. And how to avoid lung damage and damage to other organs. And
that's actually one of my patients. That actually is a 32-year-old African American man that worked in a hospital, but he worked in the cafeteria of the hospital serving people. He presented to us with shortness of breath, and what you can see depicted in this image is that the right lung, the lower part of the right lung, is gone. By gone, I mean it's completely covered by the inflammatory response that COVID gives you. So this is a person that is very sick. In his case, he only had one area of the lung that was bad. We avoided to intubate him. We avoided to put a tube on him because we knew, like I told you, if we put the tube in, that would get him in trouble. Now, this is extremely important that we discuss because you were mentioning earlier elderly people. In our experience and what we have seen in the United States is that the young people are the ones that are getting the infection the most. I have tested over 40,000 people for coronavirus, doing a drive-through testing. 40,000. I know it sounds like a big number, but it's not even close to what we really need. Of them, the vast majority of people, 80% of people, are people of color. African Americans, Hispanics, Asians. 80%. And what gets you most is that most of the ones that get it, especially the ones that get it bad, are young African American and young Hispanic males. So I know that, in Europe and in China, a lot of the people that got into trouble were those who were over the age of 65 and things like that. But in the United States of America, we're not seeing that. We're actually seeing that the young people are the ones that are getting in trouble, and we cannot explain why.
Okay. So this concept of avoiding intubation as much as possible, if you see that slide regarding recovery deterioration, maybe you can comment on that about how the general scheme for respiratory support.
Well, the first thing that you need to understand is that, like I said, we manage these patients differently. Whereas in some other instances, I would not allow somebody's oxygen to be kind of low, and I get very aggressive and I intubate them. When I have a patient with COVID, I do what is known as accepting permissive hypoxemia. That means I accept that the patient is going to have a little low oxygen without being low enough to get him into strokes or stuff like that. So I will do whatever I can to keep him at an oxygen level that is safe. But for that, I will titrate the amount of oxygen that I give them based on the low number that I want. I don't want to keep them at 100% for oxygen. If they have an oxygen of 85, I'm very happy. I give them what is known as high flow nasal oxygens. contrary to your normal little oxygen cannula that you use, where you can give 2 to 6 liters of oxygen, I actually put them on a special oxygen cannula that can give up to 60 liters per minute. So I do that. We have seen that patients that are laying back on their backs tend to have low oxygen. So what we do is we flip them like a pancake and then put them on their abdomen, on their belly, and their oxygenation improves. So we try to keep them on their abdomen as long as they can tolerate it, as much time as we can. We try, like I said, to avoid intubation, because once we get the patient intubated, our concern is that the ventilator does more harm than good. So you know how at the beginning of this pandemic, there were governors looking for ventilators because they didn't have enough ventilators, and we were using the same mentality, the same critical care mentality that we have used for the last 40 years, which is put tubes, put tubes, put tubes. But now that we are recognizing that putting a tube is actually something bad, we'll do whatever we have to prevent that. Now, if the patient requires a ventilator, we use very specific ventilator settings, if you want to call them like that, specific pressure values that we're trying to do to keep the patient from having more damage to their lungs related to the ventilator.
And all of these protocol is something that has been developed collectively with Professor Marik and others. That's
correct. We have a group of people. Dr. Umberto Meduri, who is a big mechanical ventilator person and an expert in cortisone and cortisone-like periods. We have Dr. Jose Iglesias. We have Dr. Pierre Curry, myself. I mean, we started as a group of 5 clinicians with the same goal in mind, which was let's go ahead and treat the issues that are being caused by the coronavirus in a manner that is a little different than what we do on a day-to-day basis. Let's focus on treating the inflammation and then see if we can stop the cascade of events somehow, instead of just supporting the person with ventilators and ECMO machines and things like that.
Okay. Can you comment on this MAST plus protocol, which is central to this working group's activities?
Yeah, I'll be glad to do it. When we were working on this, we have to come up with something that would stick to people's minds, and we needed to explain what were our real goals on the treatment of patients with COVID. Well, one was to decrease inflammation. The other one was, like I told you, to kind of reduce all these reactions that occur in your body. The other one was to avoid clots. So we came up with the mnemonic of MATH. And by MATH plus protocol, we mean M is as in methylprednisolone, which is a cortisone-like agent. A, ascorbic acid, vitamin C. H, heparin. And T, which would be the thiamine, and the optional treatment components, which would be zinc, vitamin D, and so on.
Okay. What about, there is a picture of you. Maybe you can explain about how, your outfit and the picture of you, but how do you protect yourself? How do you protect the medical personnel in your hospital?
I mean, we are very picky as to how we do it. We don't, we know that we're dealing with highly infective patients. We know that, like I told you, we learn every day something about this virus, and there's many unknowns. So we try to protect ourselves as much as you want. In the picture that you have depicted, you see me wearing a protective equipment. And actually, the way it happens is kind of fascinating. I get to the hospital, I take off my regular clothes, and I get some special disposable scrubs, like these ones, but disposable. Then on top of that, I get the PPE, the white one that you see depicted there. On top of that, I put in the other blue gown, and then I use 2 N95s. I'm very picky. I don't go for 1. I go for 2, because every N95 I have tested has some leak somewhere. So I do 2 N95s. I have goggles. In addition, I have a special shield on top of me. Now, the reason why I have a picture of myself on top of the gown is because once you are a patient and you enter one of these COVID units, most people are going to come in and looking like that in a spacesuit. And you don't know who's treating you. I mean, it's the most scary thing that can happen to a human being. So trying to humanize a little bit what's going on, I came up with the idea of, hey, why don't I just put a picture of me outside? And it's a lot of people have followed this crazy thing all over the world. And it's kind of funny when I put a picture of Brad Pitt inside to see a patient and they just laugh, I mean, because they know that we're having fun. But you want them to have some things. Most of actually in my unit, everybody, whether it's a medical student, whether it is the cleaning lady, everybody comes in with a picture so that people can identify with them.
So who is on the picture with you?
In this picture, I have one of my nurses. Her name is Jerusha. She's been working with us since the beginning of opening our COVID unit.
And so you are able to keep yourself and the staff safe at this point in terms of...
As of today, since March, we have not had a single member of our staff that had gotten coronavirus from the work environment. I mean, I knock on wood that will continue to be the case, but we've had instances where we have CPR, where we have emergencies, where we have to do things like that 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 they are virus generating procedures. We try. I mean, we really try. Is it 100% safe? No, it's not. That's why what we do is that's why so many people are reluctant to see patients in the COVID unit.
Okay, let's talk about early treatment and maybe the role of telemedicine.
I have several friends that have tried to do telemedicine with very dismal results. The only person that I know that can do a good job with telemedicine is Dr. Joseph Gath, who works with me, and he's a co-director of my COVID unit. He's an he's an infectious disease doctor he's very good. And what he does is he creates a series of what he calls doggy bags for the patients with azithromycin, vitamin C, all the other stuff. Talks to the patient using some kind of a video platform, gets an idea of whether they are breathing difficulty. If they are doing that, he sends them straight to the hospital. So telemedicine can be used. However, we did something. We went even one step forward to that. One of the things that I told you is that we tested over 40,000 people. Well, out of those 40,000 people, we have about a 9% positivity rate. When you have 9% of 40,000, that's a lot of people that want answers. And many of them want to be seen face to face. So we created what is known as a COVID specialty clinic. So I have a clinic in own area of the hospital just for people that are positive for COVID, that has its own CAT scan, its own radiology department, laboratory testing, everything is on there. So they come in, they are seen by an internal medicine doctor that answers a lot of their questions. Should I use this? Should I get intravenous vitamin C, for example? Some people come and they have read about the math protocol and they come and ask those questions. Some people ask questions like, am I going to die? Even though they have no other symptoms and they just tested positive. So that's one of the important things. That's one of the challenges that we have.
Can you explain this in Houston? So is testing free? People can go and get free testing?
Yes, it is free, but people are reluctant to get tested. And they do so because of the stigma that you get when you get diagnosed positive for coronavirus. Very similar to the stigma that people used to have when you have HIV. We were the first ones to create a drive-through process where people go in, and that's where we have done the 40,000 people. And we've done it through a series of 5 different locations. And yes, we have been actually paying for this out of our own money. That's the hospital's own money, in hopes that the government, they say that they're going to pay for all the testing for everybody that's tested. We hope that will be the case. If not, I will have no job in the near future. So that's what the goal is. In the United States in general, the president has been very clear that anybody that needs to be tested can be tested for free.
And once the test is done, what's the process? How is it communicated to the person? How do you
Well,
get them to show up at that clinic?
well, and that's the most difficult part. The first thing that I do when I get a positive test is I call the Department of Health in Houston. So they are the first ones that they get called. Then we call the patient. And then we tell the patient, follow up with your primary care provider. However, if you don't have a primary care provider, then we give them the number to our clinic and we arrange for them to be seen in the clinic. But one of the things that we are not doing, and we're actually going to start doing now because of lack of time and funding, is contact tracing. It's not just to tell you, you have positive COVID. We need to know who you have been in contact with so we can make sure that everybody is at least informed of what's going on. And that is a very difficult, very, very, very difficult job. And despite the fact that I have tested over 40,000 people, the city of Houston is 4 million people. So in the ideal world, everyone in the city would be tested. That would allow you to at least identify where are the hotspots where people have COVID.
And for most people will have some form of health insurance, but some people don't.
Well, actually,
how do they proceed?
That's interesting because last night I was working on that at midnight, and what I have found is that 33% of all the patients that turn positive are asymptomatic. That means they have not a single symptom. And these were people that were tested just because we keep on pushing for people to get tested, whether or not they have symptoms. And that's the most scary situation. And that's why contact tracing is extremely important, because you may have somebody that is completely asymptomatic doing normal activities and maybe spreading the wealth to everybody else.
But okay, that's a substantial point. But if I may ask, people who don't have health insurance in the U.S., how do they get treatment if they cannot afford it?
The government has promised that they will be paying for the expense of anybody that is admitted to the hospital with a diagnosis of COVID, whether you are insured, uninsured, legal, or illegal. So to that extent, we're lucky. And again, that's what the government has said. We don't know if that's going to happen.
Okay. But so you are admitting the patients essentially.
Oh, and even if they didn't do it, I'm a doctor. We will admit them. We take care of patients without or despite insurance. That's not an issue. But the cost of caring for a patient in the intensive care unit with COVID may be quite excessive.
What kind of range is it per day?
If you think that a normal intensive care unit cost is about anywhere between $5,000 and $6,000 a day, imagine that COVID is probably twice as much. From the equipment that you have to dispose, to special machines, to special treatments, even though the math protocol that we use is ridiculously cheap.
Okay. Can you tell us about, and I'd like to show you first the slides that were presented by Professor Raoud on the May 19th, and essentially what he explained on those slides is that if there is no early treatment, the likelihood of having young people suffering from the disease is much higher, and mortality including. Can you explain what's your message to young people and how you deal with young people at the testing, at the diagnosis stage, etc.?
The only way by which I've been able to bring young people to events that I have organized for testing has been to bring musicians or people that they can identify with. Young people believe that they're invincible, that nothing will happen to them. And the fact is that young people are equally sick as old people. And I have seen a lot of young people outside the hospital setting drop dead because they thought that, it was just a common cold or it was nothing. So the message to the young people would be, make no mistake. We have two kinds of people in this world, those who have COVID and those who are going to get COVID. Sooner or later, we're going to have this transmission. What you're hoping is that you will have enough immune system, whether via means of a vaccine or herd immunity or any other kind of immunity that's going to protect you. But we are not at that stage. And young people get in trouble and young people die. The other thing that we understand also is that the sooner you get treatment, the less likely you are of dying. A couple of days ago, I had a gentleman that came to me with 2.5 months of symptoms. He had refused to seek medical attention. And when he came to me, maybe his COVID itself wasn't that active, but his heart function was almost non-existent. His heart was so damaged by the COVID and the lack of him seeking medical attention that that was getting him into real trouble. Had I seen that man 8 weeks ago, and we had started him on the Math Plus protocol, more likely than not, that gentleman would not have ended up with a very poor functioning heart as he did when he came to see us.
And how do you think it's possible in a city like Houston to send the message to if you get any form of symptoms, get tested, get treated early, go to see your doctor as soon as possible?
It's almost impossible. I mean, social media has helped us a lot. I do a lot of media stuff. I've been interviewed by a bunch of different, TV channels and stuff like that. And my message continues to be the same. I tell people that, testing, and retesting, extremely important. And if you have any symptoms, you have to be seen. You have to be seen. Whether you're going to do it telemedicine, whether you're going to do it via phone, whether you're going to do it face to face, if you have symptoms, you have to be, because people are dying. And there is no need for them to die. Again, we have options to treat corona, and we have shown it with the Math Plus protocol. At least that it treats the effects of the virus. It may not kill the virus itself, but it may stop the effects of the virus infection. So that in of by itself helps. But if I don't get you on time, I'm not going to be able to help you.
You emphasize that no, we don't necessarily have to die from it. What has been so far the kind of success rate you have had with you dealing with sick patients?
Well, we have been very fortunate, and our success rate in the last 8 weeks, having treated more than 60 patients in the hospital, it's 100% success rate. 100% success rate. Having said that, my colleagues in the medical center in Houston, they all have the same success. They have a very high mortality rate. But, like I said, I like to get them early. The earlier I get them, the better off we are.
And you have a ward that is for sick patient, which is not intensive care, and then you have intensive care. What is the balance between the two?
Well, I mean, in this day and age where we are so swamped with patients, especially the last week, I have seen a surge in cases. Despite of what some of the TV stations say that that we are having less cases, we are seeing more cases. And I don't know if we are seeing more cases because we're becoming a center of excellence for COVID, or because there are more cases. But I am attributing that to the fact that we have opened the state back, and the economy is coming back, and people are going out, and people don't seem to care what's going on. They go to the beach, and they go to bars, and this social distancing is not occurring. So I believe that that's why we're seeing more cases. So sometimes I have to allocate beds that are not meant to be ICU, and I turn them into an ICU. I created a COVID unit in which I have 20 beds for ICU, and then I have 26 beds for kind of intermediate care. But sometimes they overflow from one side to the other just because I get too busy.
Okay. One of the articles on our blog is about the elderly, and I was quite amazed by, and it's all anecdotal as people say, but you have people up to age 104 who got treated with hydroxychloroquine and survived. And so there are many stories of survival thanks to this kind of treatment. Can you tell us about how you cope with elderly people who have the disease?
Yeah, well, and again, remember, the United States of America is a little different than some of the other countries. Here, you treat until somebody tells you don't treat anymore. I mean, it's basically what it turns out to. Because of all the concerns about lawsuits and things like that, we tend to treat a lot. So recently, I had a very sweet 90-year-old woman. She had history of colon cancer, had cancer in her intestine, that has spread to her lungs. But this was a lady that she liked to live. She was very feisty, and while getting her chemotherapy, she developed coronavirus, and she came to us. And my first question was an ethical question. I mean, am I going in to allocate all the resources that I have for this 90-year-old woman that has history of colon cancer that has gone up to her lung, or do I let her be? But, feisty woman that likes to live, and I said, why not? So we went ahead and we treated her with the hydroxychloroquine, azithromycin, and the MAF protocol in general. And she survived. And she actually, I just heard from her a couple of days ago, she's continuing her chemotherapy. She's doing fantastic. Fantastic. She actually made the news, and because it's one of those cases. So the way you cope with it has to be done on an individual basis. It's not the same to have somebody that wants to live and is doing okay, that somebody that has had 1 million strokes, is living with a feeding tube, has a tracheostomy in place. There are too many issues that you need to consider.
Okay, and the related question is about elderly homes, and as you know, there are issues of infections and a lot of fatalities in elderly homes in Canada, in the US, and elsewhere. What do you think are the implications of your knowledge in terms of dealing with these elderly nursing home crisis?
There are two. One is political, and the other one is medical. And let me tell you, I've been getting a lot of those patients coming to us. The governor of the state of Texas made it mandatory that every nursing home, every elderly home is tested for COVID. Every single one, both patients as well as employees. Because the number of cases that we're seeing coming from those nursing homes is just escalating. And that's despite the fact that you cannot go and visit your grandfather or your father or whoever is there. They are pretty much locked down.
And have you heard about that doctor, I think Dr. Armstrong, who treated in the nursing home with hydroxychloroquine his patients?
Correct. Yeah. And again, I am not familiar as to how he did the actual treatment inside and how he determined who would get it and who wouldn't. That I'm not familiar with. But I will tell you that if it's based on my own experience, having dealt with a lot of elderly patients with COVID, it works. It works. And that's why those academicians that say that we need to do a randomized, double-blinded study where you're going to give a sugar pill to somebody and the other one is going to get the real thing, I think that at this point in time is an unethical request, because what we're doing is working. Why am I going to take that away from 50% of the patients to try to prove what I already know that works?
So in that regard, and without opening completely that particular aspect, what do you think about the results of Professor Raoult in France and especially the study on 1,061 patients, where he has over 90% success rate in terms of survival rate at least?
I'll tell you, it's something that we have replicated to some extent. Again, the way we do things are a little different, but that's his data, and it's difficult to refute it. Like I said, I hate to politicize drugs when they seem to be working. And the fact is that agents like hydroxychloroquine, they have been around for decades. We've been giving them to patients with rheumatological diseases forever, and I've never heard anybody come and say, these patients are dropping like flies, and everything is being politicized. Why won't we just forget about the politics and do what's right for the patients, and then give them medications that are working? And there are a lot of medications in the pipeline that are very interested and that are coming in, and we're testing several of them that are fascinating. But we're not there. The vaccine, we're not even close to get to where it needs to be. So We need to work with what we have. This is a time of war. This is not your regular situation, in which you have your sweet little time to conduct all these experimental trials. Here we're trying what we can, and what works, we need to stay with it.
How do you explain the large number of medical doctors, of people involved in the research, who totally dismiss anything that is different from a randomized controlled trial, and who dismiss the work by Professor Raoult? How do you explain that, as maybe you can talk as an academic here?
Well, I've been an academician all my life, and I do respect the randomized controlled trial when you have a chance to do it. We don't have time for randomized controlled trials at the present time. And those people that want a randomized controlled trial clearly are not on the front lines. I am on the front lines. The Math Plus protocol was created on the front line. All the people that you see that were working on these patients, the critical care consortium that you're familiar with, Professor Marek, Professor Iglesias, Professor Meduri, Professor Corey, we are all working on critically ill patients at the bedside, not from a desk, not across the street, not on a lab. We're working right there, and we're seeing what works.
And if someone challenges you and says, well, you cannot prove that it works, what are you saying?
Oh, it's very simple. You are correct. I may not be able to prove that it works in paper, but the facts are the facts. I have a 100% success rate. None of my patients have died. Whether it was the hydroxychloroquine or any of the other elements of the cocktail that we give remains to be determined. I agree with you. But for the present time, I'm not going to remove anything from my protocol until somebody doesn't tell me 1,000% sure that that's what would be causing something terrible. And as of now, I have not seen anything terrible.
And in terms of research, are there aspects that you think should be focused on in the very, very short term to help you in being even more effective in the way you treat patients?
Yes, and they are. I mean, I'm actually working right now with a compound that is known as DAS 181. And what that does is it's a special compound that originally was developed as an antiviral for flu. But when this was tried in Wuhan, China, they actually found that those people that were taking that as an antiviral for flu, they were not getting the corona. And what it does, it basically blocks off how the coronavirus gets stuck to the cell. And it's a fascinating protocol. It's a fascinating medication. There are two centers in the United States that are trying it. One is my center, the United Memorial Medical Center. The other one is Johns Hopkins Institution. And we have enrolled so far 6 patients. This particular one is a randomized controlled trial. So you need to understand, I have them on my regular math protocol without hydroxychloroquine, without azithromycin, and then they get randomized to receive either the real thing or placebo. So in that sense, I feel comfortable because I know that at least my patients probably will not die. And in addition, we're looking at how much virus they have around, what changes they have in their cells. So it may be a game changer if it works.
Interesting. That brings me to a side question, but an important one, especially as I think 2 days ago, India they decided to use hydroxychloroquine as a prophylaxis. The Chinese, can't remember the name of the researchers, but they came with this observation that they couldn't see any patients, lupus patients developing COVID-19. Do you think there is a similarity in terms of the mechanisms that you just described with the way the lupus patients may be less prone? And how do you see the process? Because I think it was recently in the media, some lupus patients came out and said, I'm a lupus patient, I'm taking this, and I got COVID-19. How do you see this question of prophylaxis and ability to to prevent kind of development of the infection?
The first thing that I would tell you is that we shouldn't be comparing populations at the present time. I mean, the Chinese population is very different than the American population. The Chinese population, as you know, it was the elderly, the ones that were dying or getting in trouble. The American population, we're seeing all these young people getting in trouble. So there is something that is there that is different. Having said that, I don't think that there is 100% success for everything when you try to use it across the board. So I'm not surprised that there will be some patients that say, hey, I have lupus, I've been on this agent for many years and I just got corona. But also, the question to that particular lupus patient is at least you can talk about it. So even if you get it, the extent or severity of the illness is clearly much less than somebody that has not taken it. Using it alone, prophylactic, it's up in the air. I mean,
anyway, do you want to add anything for our audience?
I mean, just as a concluding remark, I think that people just need to be aware that I think that the groundwork that we need to do one more time is testing, and retesting. Identify where the problem is. If you identify where the problem is, then you can avoid other people from having the infection, and then you don't have to worry about math or any other protocol. The second part is if you have the illness, early treatment makes a difference. And third, if you are in the hospital, avoid intubation at all costs. Whatever you can do to avoid intubation, that will do it. And lastly, there are some promising therapeutic interventions that may be coming up in the next few months.
Thank you so much for your time. It's amazing. I think we covered a lot, and I think the video will be watched by all those who are in dire need for information. And we have to thank you again for your time and for your devotion to taking care of patients.
It is my pleasure. Just send me the link once you get it, then I'll make sure I make it go viral.
Thank you so much.
See you.
You're
Good
welcome.
day.